Very good afternoon, friends and colleagues. It is my pleasure to present to you the 2010 guidelines on cervical screening. There's not been very much change, in fact, hardly any change at all in the overall key recommendations, although there have been some new comments that we have put in because of some new things that have come up over the last 7 years. This slide basically shows to us the latest statistics from Singapore Cancer Registry, which shows to us that among the cancers in Singapore women, cervical cancer is number 6 on the list and the third commonest among the gynecologic cancers. In the last 3 decades, we can see that the incidence of cervical cancer has been slowly declining, and since the last clinical guidelines, the incidence has fallen from about 10.6 to currently about 8.8 per 100,000. What we do know, of course, is that infection, or rather persistent infection with HPV, the human papilloma virus, is a key requisite for the pathogenesis of cervical cancer. Over a period of about 10 to 15 years, persistent infection will then progress on to cervical dysplasia, also known as CIN, or cervical intraepithelial neoplasia, before manifesting as a clinical lesion on the cervix. From the cancer registry, we know that the highest number of cases of CIN occurs between the ages of 35 to 44, and the peak incidence of invasive cervical cancer is around 10 years later, between the ages of 45 and 4. So this very nicely supports the slow rate of pathogenesis from cervical dysplasia to invasive cancer. The data also shows to us that when we're looking at high-grade CIN, the CIN3s and the CIN2, among the teenagers, the incidence of this pre-invasive disease is very low, only about 0.3%, and then from the ages of 20 to 29 in the second decade is about 10% of all the CIN3s. And then in the elderly age group above 70, again the incidence is quite low, about 1.5%. When we look at the invasive cancers, only 5 cases occur in women under age 25. So in the young women, we do see some cervical cancer, but it is indeed very uncommon. And in the women above the age of 70, about 1/5 will occur in this age group. So among the risk factors, of course, once again, a woman with persistent HPV infection will be at the highest risk of developing cervical cancer. Conversely, if a woman has never had infection with HPV, so for someone who's never had any kind of sexual contact before, she will almost certainly never develop cervical cancer. All the other risk factors point towards, or rather they act as cofactors in the development of cervical cancer. For example, HIV, immune suppression, cigarette smoking, all will modulate or reduce the ability or the immune system in being able to clear the cervix from the viral infection. The other factors like multiple sexual partners, onset of intercourse at an early age, or the history of many sexually transmitted infections act as a cofactor in increasing the viral load, leading to a higher chance of persistent infection. And what is also we've added in this year is the long-term consumption of oral contraceptive pills. The combined OC pills have now been shown to be a definite risk factor in cervical cancer, particularly the adenocarcinomas. But this obviously shouldn't affect your prescribing habits, in the sense that they do have many other health benefits in terms of birth control, as well as the proven prevention of ovarian and endometrial cancer. So if you prescribe these pills to the women, at the same time you should ensure that talk to them about cervical screening on a regular basis. The low risk factors would be, as I mentioned just now, women who have never had any kind of sexual contact, and secondly, women who have had a total hysterectomy in which the cervix was also removed for benign conditions. So all they have is the vaginal VOC, which will very rarely develop HPV or persistent HPV infection or dysplasia. And certainly vaginal cancer is a very rare condition. So who should be screened? The same guidelines have not changed, starting from the age of 25 for those who have ever had sexual intercourse. The International Agency for Research in Cancer recommends screening only from the age of 25 because there is minimal benefit, and in fact can be very harmful if you screen teenagers and those below 25, because at this age group they are sexually active. Many of them will have transient HPV infection, which will be picked up on your cytology screening as low-grade disease like like CIN1 and sometimes CIN2. The vast majority of these young girls and young ladies will be able to clear the HPV infection spontaneously without any kind of treatment or any kind of intervention. So to screen them and then to pick up the disease will cause a lot of anxiety, unnecessary referral for colposcopy, biopsy, treatment, scarring that will eventually lead to cervical stenosis and even cervical competence that will affect their fertility adversely. Previous recommendation in 2003 to stop screening at the age of 65 is now changed to 69 to make it in line with recommendation on the breast cancer screening. For a woman who has reached the age of 69 or 70 whose pap smear very recently is negative, and if she has had 2 previous consecutive negative pap smears, she can be discharged from routine screening. So how often should we screen these women? Same as before, we recommend screening from every 3-year interval, and of course this does not apply to women who have been treated or on follow-up for cervical dysplasia or cancer. The screening interval benefits are dependent on the age of the women screening, and the benefits are incrementally better for the younger women, and the details of these will be in the guidelines that you have in front of you. In special circumstances, like we mentioned before, for women who had a total hysterectomy for benign causes, they do not need to be screened if they have had a normal pap smear before. For those who have problems with their immune system, certainly they should be screened more frequently, annually and earlier. The HPV vaccines have now become very commonly available, and many of you will be prescribing it in your clinics. Remember that these are targeted only to type 16 and 18 high-risk oncogenic viruses, and these 2 viruses constitute 70% of all the cervical cancers, and the women still need to be protected from the other 30%. So in spite of having completed their vaccination schedule, they still need to be screened regularly under the national guidelines. So what should we do? What kind of screening test should we do? The pap smear continues to be very well established in fulfilling its role as an effective screening test. Nowadays, the liquid-based cytology is also very widely available. The 3 major institutions have now switched completely to liquid-based cytology, but majority of labs and probably clinics are still using conventional slide-based cytology. So either kind of cytological screening can be used, either conventional or liquid-based. You will also be approached by many companies who will be able to do HPV DNA testing. At this point in time, we do not recommend this as a form of primary screening for cervical cancer. The data does show that if the test comes back negative, the negative predictive value is very good, but if the test is positive, the actual referral algorithms have not been properly worked out. We don't know the cost-effective balance in the use of HPV DNA testing for our population, so we would not recommend using this as a form of primary screening at this point in time. What should we do? What kind of screening test should we do? The pap smear continues to be very well established in fulfilling its role as an effective screening test. Nowadays, the liquid-based cytology is also very widely available. The 3 major institutions have now switched completely to liquid-based cytology, but majority of labs and probably clinics are still using conventional slide-based cytology. So either kind of cytological screening can be used, either conventional or liquid-based. You will also be approached by many companies who will be able to do HPV DNA testing. At this point in time, we do not recommend this as a form of primary screening for cervical cancer. The data does show that if the test comes back negative, the negative predictive value is very good, but if the test is positive, the actual referral algorithms have not been properly worked out. We don't know the cost-effective balance in the use of HPV DNA testing for our population, so we would not recommend using this as a form of primary screening at this point in time. Obviously, with screening recommendations, it's important to know how effective the screening program should be. What we do know is that a nationwide population-based screening program that collects data from all the smears performed in the country should be implemented. An organized population-based program with good population coverage and recall mechanisms will definitely reduce the incidence and mortality from cervical cancer compared to opportunistic screening. And this has been proven all over the world, especially in North America, in Northern Europe, UK and Australian program. At present, most of the cervical screening in Singapore is largely opportunistic. Health Promotion Board has done a great job in launching the Cervical Screen Singapore 4, which has a recall mechanism to remind women to attend for screening every 3 years. However, this is presently only limited to women who consent to register with the program and have their pap smears performed in the polyclinics. If we have an organized population-based cervical screening program, then we can expect to see a reduction in mortality from cervical cancer and also cost savings. Screening strategies and studies, especially in Hong Kong, have shown to us that cytology-based opportunistic screening is more costly and less effective than having an organized program of screening every 3, 4, and 5 years. To sum up, the key recommendations from the latest set of clinical practice guidelines remains largely the same as before, that all women who have ever had sexual intercourse should be screened from the age of 25 years. Screening should be performed at least once every 3 years, and screening should continue to be performed using the pap smear, either with conventional slides or liquid-based cytology. I'd like to thank and acknowledge the members of my subgroup for all their hard work looking up the literature and drafting out the guidelines, and thank you very much for your attention.